All right, I'm Kate, and I'm doing my presentation on social or pragmatic communication disorder. I've always been kind of interested in this domain of language because in audiology, one of the first things we always ask for peds is how is their speech and language, and I think the focus gets really focused on if they're able to hear sounds and if they're able to create a vocabulary, but sometimes we don't always focus on if they're using language appropriately. So the signs and symptoms of STD, social communication disorder, is a persistent difficulty in the social use of a verbal or nonverbal communication. So these people have a really hard time understanding greetings and sharing information in a social situation. They also have a hard time when you change modalities in different communications. So it's not natural to them to talk differently to their parents than to their friends, than to their boss or coworker. They also have difficulty following the rules of conversation, so taking turns, understanding when someone's telling you a story that there are certain things that you're expected to do when someone tells you different things, or anticipate needs and share feelings. They also don't always understand what's not explicitly said, so inferences, idioms, metaphors, those are all things that they don't pick up on naturally. So it's probably going to sound similar to a lot of other neurodevelopmental disorders. So there are certain ways to distinguish it. The onset of the symptoms do occur in the early developmental period, but they don't become really evident until a child's growing up because our demands for social communication become more demanding and more intricate as we get older and older. And it's not that the children are regressing, it's that they're not keeping up with their peers. They're not learning how to act appropriately in different social situations. It's also important that the symptoms are not attributable to another medical or neurological condition. And so I know what I'm talking about probably sounds a lot like autism spectrum disorder. But actually one of the ways to diagnose SCD is a child that has gone through a diagnosis for autism and they don't have it. They don't have all the other behaviors and responses that someone with autism does have, but they have the deficits in particularly social communication. However, to muddy the waters a little bit more, it can co-occur with other problems like ADHD, expressive language disorder. A child can have hearing loss and social communication disorder. It's also really important to distinguish it by knowing that the symptoms are not a problem with the child's vocabulary. They understand the rules of language. They know how to put sentences together. They know how to use the words. They just don't know how to use them in an appropriate way. If that makes sense. There's really not a lot of data, or any data actually, that I could find on the incidence and prevalence. It's a pretty new diagnosis. I think it was only put in the DSM about 3 or 4 years ago. Did you say 2 years ago, wow. So it's really, really new. There's a lot of inconsistency with the definitions and across sources, and a lot of people think it's part of other disorders and don't really recognize it as its own diagnosis yet. It's usually diagnosed depending on where the child ends up first, a speech-language pathologist, psychologist, an audiologist. If a child's having trouble with language, hearing is one of the first things that we check, and so an audiologist will be part of that diagnosis team. Treatment usually starts with a speech-language pathologist, but then it really needs to be a team effort that branches out to if a child's working with a psychologist. The whole treatment is to work on skills. So you want them to learn how to take turns in conversation. You want them to learn how to share their feelings and tell stories and anticipate what's going on next in a story. And work with one friend and then understand that that's different than being in a whole classroom. And so you start kind of one-on-one, and then you want to branch it out. You want that child, parents, teachers, friends, family, you want them all to be part of the team that's helping this child work on their skills. And the research that I have found really does say that that's one of the best ways to see improvement in these children. You can't expect them to pick up these social cues naturally, and one of the biggest things that I do see is that I did read in a few different papers, was that it's really detrimental to kind of throw a child with STD into a demanding social situation and just expect them to pick it up, because that can really lead to like inappropriate behaviors that lead to isolation and teasing from other families. So what you want to do is encourage social interaction while teaching these skills and giving them their support.
Remembering the alarm go off because you're just under 5 minutes.
All right. Question.
Yeah, I'm glad you did this one. This is, as a neuropsychologist, I do a fair bit of work with kids and separating out between this versus autism, because you get a lot of referrals for this type of stuff, and it's like, well, it's got to be autism because this is what we see, but they're lacking the stereotype behaviors and sensory issues and everything.
Yeah.
The other behaviors that are, characteristic of ASD. That said, this is also, it's a new diagnosis. We don't know a lot about it at this point, and so I think that it's nice because it captures a lot of what the parents report, but there's also a lot of questions about exactly what it means and what etiology it is, what happens over time, those kinds of things.
I would agree with that. A lot of the research that I was looking into for this was actually ended up being papers about looking at autism and then finding that there's another population of people that this is really the defining feature of what they're struggling with.
It seems like there must be quite a spectrum, and I don't mean autism spectrum, but a spectrum of the skills, because some individuals are socially more awkward in their kind of, and it takes a little longer to figure it out, but they can figure it out. Yeah. And I think maybe if it's so new, it's going to take us a little while to sort of say, where does it go from being just somebody who's socially awkward to someone who has a disorder, a diagnosis and a disorder.
And it's a fair point. It's like, it's not something that I diagnose a whole lot because of that, because it's, ADHD, you tend to get similar type, like somebody who's highly impulsive, who can't attend a conversation, you get a lot of this stuff, but is it really this, or is it just kind of ADHD, and once we manage that, we get improved social connection?
Yeah, for it to qualify, in the DSM, I looked it up, that you have to have persistent, there's like 4 different, and it's at multiple of these 4 different skills that they've laid out, but I would agree.
I was going to ask, did you see anything about the use of social stories to help with, skills building?
Yeah, there are a lot of different different strategies that many people are using, and that was one of them. Yeah.
So I was just going to say, we see a lot of that, like you said, in autism, and having a daughter with Down syndrome, I see this a lot in the the population of people with Down syndrome. Who, my daughter, she'll just pretty much tell you how she feels, but and if she say hi, we greet people happy, but they would test you. It's on her own terms. So I mean, how do they think those are kind of the same things, or this is something completely different than those same kind of skill sets that you do see in children with neurodevelopmental disabilities?
I'm not sure what you mean by do you think it's the same thing?
Do you understand what I'm saying?
I think I do. I think it's so. Let me reframe that. That you're kind of assuming with your daughter that some of her social interactions, like when she'll come up to me and not speak to me, or another time come up to me and give me a big hug.
Right. Does that have to do with the cognitive
disability? Is that because of
or?
Her, cognitive disability, and kind of just part of having Down syndrome and cognitive disability, or does she also have a social communication?
Right. Are they completely separate, or?
That's one of the things that's really hard to tease apart. This. Because it's its own diagnosis now, it's stated that it can be its own, but it can't be attributable to another medical or neurological condition. So I don't know enough about Down syndrome, if that's part of what the diagnosis is.
That's my personality.
Yeah, if that's part of it, then it probably wouldn't be its own separate diagnosis, but I don't know enough about it to
Thank you.
say. Did you have a question?
This, like a lot of symptoms and syndromes and diagnosis, this is based, it looks like, mainly on behavioral symptoms, right?
Yeah.
Is there any evidence of a cause for those, an independent cause? And I ask that because a lot of times in diagnostic work, we tend to label something and assume that that cause exists, even if we don't have any independent verification.
Yeah.
So is that a problem that may happen here also?
I think it might be. The reason why I'm interested in it is I actually did a research project a few years ago through audiology, where I was looking for reasons why a child with hearing loss who might have had no speech delay, but they, as they get older, we see issues with their pragmatic communication skills, and if oral rehabilitation would help with that, because if you can't hear things quite as well as all of your other peers, if you're really picking up on those social cues as well. So I don't know, I haven't seen any research on it, but it's something that I'm really interested in. Yeah.
Thank you.
Perfect.
Well, we need to let it go.
for what we are learning about here. So, a genesis is the partial or complete absence of an organ during embryonic growth. So, it's partial or complete. Partial is some of the nerve fibers connect both the left and right hemisphere, and complete, none of the fibers develop enough to connect the two hemispheres of the brain. So, the corpus callosum is the most significant mechanism that connects both the left and right hemisphere. There are other mechanisms, but they're not as important as a corpus callosum. 2 to 3% of the people with developmental disabilities have a genesis of the corpus callosum, and the prevalence of the genesis of the corpus callosum in the general population is unknown. Normally, it's detected through fetal ultrasound when there are other complications, other brain abnormalities or chromosomal defects, but or MRIs. And if not caught during or in utero, then it's noticed during the first 2 years of an infant's life because they start having seizures. Now, the severity of ACC differs in populations. There are people who go throughout their lives with ACC and it's never found or diagnosed. And there are other people who have severe developmental delays and other complications associated with ACC. So that's what it looks. So if you look on the picture on the left, you see the gray matter connecting both hemispheres, and on the right, it's not as gray. You don't see those nerve fibers as strong there. So the symptoms are frequent seizures, hearing and visual impairments, social immaturity, attentional difficulties, poor feeding behaviors, obsessive behaviors, developmental delays, complications with muscle tone, difficulty sleeping, and cognitive difficulties. And this is when ACC does not occur with any other abnormalities or defects. So it is often, without an MRI, it's impossible to diagnose because there are no, if it occurs alone, there are no physical characteristics that you can see. And sometimes it may look like it manifests as ADHD. Sometimes in infants it can look like failure to thrive. And it presents a lot like autism. So there are a lot of people who are misdiagnosed. And while these and other labels or diagnoses characterize the behaviors associated with ACC, that's not the main reason. So the treatment is anti-epileptic medication, speech, occupational, and physical therapy, and early on, it's special educational services. So the thing about ACC is it takes a long time for the children to be able to progress and reach developmental milestones, but they can. Well, some of them, depending on the severity. And if we give them the wrong label, we might just write them off and say they're not going to be able to accomplish very much, and this is their life sentence. A lot of parents go online and they read a lot of horror stories that are associated with ACC, but there's I didn't include it in my presentation, but the National Organization for Disorders of the Corpus Callosum has a lot of good resources for families that show that it's not a life sentence and that with intervention and just pushing your child, much like we saw with Abby, that good things can happen and occur. And that's it.
I don't know if they still do this, but in patients who had bilateral cortical seizures that were very severe, sometimes they used to cut the corpus callosum from going from hemisphere to hemisphere. Do you get the same kind of endophenotype as you would, or behavioral phenotype as you would, as someone who was born with a congenital defect? Do you know?
Can you restate that?
So if it's cut after birth, are you going to get the same kind of symptoms?
If it's,
The corpus callosum, as if it was never grown to attach the two hemispheres?
Oh, I'm not sure, but we have a neuropsych in the room, maybe.
That's smart.
From my experience, I'm the developmental component, and it's not always a complete agenesis of the corpus callosum, so you still do have connections, at least to some degree, going through, and then the surgical procedure is often, when they cut it, it's after, it's usually, later on they've developed, and also there's usually a reason for that, seizures, and so there's different developmental things. So the presentation is different.
Is it split brain? Is that what they?
That's the procedure where they separate the corpus callosum. There are other procedures that they do as well. Major seizures.
Did you come across that? Because my nail is fetal alcohol spectrum disorder, so I always So this is one of the things that happens to kids who are prenatally exposed to alcohol. It's one of the big things and causes a lot of issues.
Right, so this is one of the causes, but there's a lot of, when it doesn't occur or with another cause or another syndrome or another defect, they don't really know what causes it. But yes, FAS is one of the things that can cause partial or complete.
Also, one of those interesting things, as you mentioned, is that, there's, unless you get a brain scan for some other reason, it's not often identified. So there's a lot of people that have different brain structures that are different that are fully functional and doing things.
The brain has specialized and lateralized functions, and it seemed like the genesis of the corpus callosum would really interfere with that, but the brain also has some level of plasticity, doesn't it?
Correct.
So I'm wondering whether or not the congenital version of it would result in more bilateral functions or other ways that the brain compensates for it. And I don't know that you would know this, but I wonder if anybody else knows anything about the compensation that might occur with the congenital version, not the acquired version or the surgically produced version. Whether there's any compensation in plasticity of the brain. Anybody know about that?
I didn't read any studies regarding that.
Okay.
Though they have some studies with children who are just born with one hemisphere who can kind of still grow developmentally normal. So, I mean, it makes sense that you'd be able to compensate or rewire circuitry to.
It's true.
And certainly some people that are stroke victims have brain functions that get specialized into other areas, and they don't completely lose that brain function always. Sometimes they do, obviously.
Right, so I don't know if the presentation is different, but they are able to compensate. And like I said, with time, they can reach those developmental milestones. And some go on to lead normal lives. So I'm not sure if the compensation is different than the surgical procedure, but they certainly are able to function similarly.
If you could detect it, early intervention would be a pretty good.
Oh, definitely,
Yes, that
definitely.
would be good. Okay.
I was just wondering if they split it for interventions, do they ever rebuild that bridge?
I don't know if you can.
I'm just wondering.
Yeah, I don't think you
The
can
level of
rebuild that
neural
bridge.
connection is,
Yeah.
you can't rewire it very well, I don't think.
Yeah, once it's gone, those neurons don't ever regenerate. That's the problem with the brain.
Yeah.
So many of them, once those connections are gone, there's no regeneration of that.
Wow.
Don't split your corpus
I
callosum.
don't There's no
It's
going
usually the
back.
clinician.
Thank you.
Good job.
I it wasn't last night that I figured out, but today's actually World Cerebral Palsy Day, and it's kind of fitting. And I was browsing the website, and there's actually some kind of information sheets that everybody can, I had 21 pieces of paper left, so I have 21 so I apologize, but we can just pass it around.
Priority to training.
Sorry, guys. Okay, so yeah, happy World Cerebral Palsy Day, and getting the word out is huge, and that's one thing that they emphasized is the policies and everything like that. But anyway, so what is cerebral palsy, and why did I do this? Because I'm actually working with a child. I work at Michigan School for the Deaf, and a child I'm working with right now has cerebral palsy and dysphagia. She has to have a very special diet. So, and it's like, okay, hey, what are some issues or what are some nutritional implications that I can look for? And that's really how I started developing my interest with cerebral palsy. It's something that I didn't know that much about, so I was thankful to have this opportunity as well. So cerebral palsy is a neurological disorder caused by brain damage in developing children, leading to muscular and malformations in the body. So cerebral means the brain, or it applies to the brain, and palsy refers to muscles. So that's where cerebral palsy comes from. So that's really the two main problems with children is the brain communicating with the body as well, and how the muscles work as well. So major risk factors, Jane and I were talking last night, or Dr. Turner and I were talking last night, and there was an old thesis that it was actually a problem, not enough oxygen to the brain for the child, but it was actually an old thesis. So science is pointing this to a small number of cases, and there's several causes of cerebral palsy, and that they're still exploring as well. So brain damage occurring before or during birth is called congenital CP, or cerebral palsy, and this is the majority of cases, about 85 to 90% of cases. So the CDC tracks cerebral palsy through the Autism and Developmental Disabilities Monitoring Network, or the IDEA network. This is the most common physical disability in children, so it's something that is very prevalent and that we may see often in our practices. CP is more common in Black children than in white children, and it's about the same in Hispanics and white children. Many of children with CP also has co-occurring conditions from there. So a little under half of the children have other health problems that we need to be aware of. So, and about 1 in 323 children have cerebral palsy, or are born with cerebral palsy. Right. Yep. So there are many different ways to classify cerebral palsy. So this is something that we have to keep in mind, is that some children or some even adults will have problems with their lower half of their body, they'll have problems with just half of their body, or problems with their whole body and their movements as well. So that's something that we do have to keep in mind, is where in the body are they affected. So that's actually the topographical distributions that we can classify cerebral palsy. Also, you can classify a mild case, a moderate case, or a severe case of cerebral palsy. Another way to classify cerebral palsy is spasticity, which is when your muscles are stiffened. Oh, okay, now? Oh, 1 minute. Okay. So it's when your muscles are tightened, or non-spastic, which is when they're more flaccid or loose muscles from there. So knowing the severity, location, and the type of cerebral palsy is important when we're in our practices and when we're watching over children. Signs and symptoms, these greatly differ, and it could be anywhere from inability to roll over, to seizures, to tremors. It's just important for patient-centered care. What does this child need? What does this adult need? So treatment, so there's a lot of different treatment. In my eyes, how do I get the best nutrition to them? In a PT's eyes, how do we create the best, treatment for them? OT, how do we help them survive day to day? Audiology, social work, everybody has a part in a child's life with CP. So even audiology as well. So that's the girl I'm working with now with her dysphagia diet. I'm learning sign. So there's a lot of communication issues with us too, so it's been interesting. Services, the Individuals and Disabilities Act. One is the Early On, so that's a resource for them, and also the public school system. So Any questions even about like the people I work with at the school or nutrition-wise? Yeah.
Is there certain types of conditions or children with certain conditions that you see more often than not? Is it like, what's your
Really,
patterns in what you see, or is it all over the
it's
board?
all over the spectrum, and that's what's so amazing about children with CP is that everybody is so different when their cases. So I have one student who can't necessarily feed herself either, so we have to figure out ways how to feed her because she trembles too much, if that makes sense. So it's just been very interesting in working with these students and working with and even how they walk. There's some kids that you have to use a walker, some kids who's wheelchair bound. So, and that's really, it just all depends on their classification and what type of cerebral palsy that they have. So cerebral palsy is really just an umbrella term for a lot of different cases or a lot of different problems that they could have.
At your school that you work at, do you have a PT and an SLP and whoever else to work alongside you, like with the feeding and swallowing and the motor impairments?
So unfortunately, no. Michigan School for the Deaf is where I work. They have amazing resources, but they really just have aides who work for CAC, and they also have a nurse, 2 nurses, but they don't have those resources, unfortunately, which it's kind of makes me nervous because this is a very special school for
That's what I was thinking,
population.
like with all the feeding and swallowing you were talking about, that's like SLP and then the movement disorders for PT or OT. It would just makes sense. That'd be a nice thing to have.
I agree. So, yeah.
Did you say you work and do different like nutritional diets?
Yes,
Yeah.
with the students.
Do you guys use like a ketogenic diet? Does it have any?
We don't do anything with the ketogenic diet. It's actually pretty controversial, and if it works with seizures and if it works with kids, I mean it's given, but we don't necessarily work with ketogenic diets at this school. Yeah.
So at the school, are they working mostly with teaching kids sign, or are they working on verbal?
So Michigan School for the Deaf is all signs, so I'm learning. And they, some kids are hard of hearing, but most, even teachers, principal, are deaf. So it's, everybody's nonverbal sign language. The kids range from 2 years old to 26 years old. So, yeah.
So the school, is it a private school? Is it a public school? Is it?
It's a state-run school. They get federal and state funding.
So how I guess I'm surprised they don't have other therapists. I mean, I'd assume these kids are on IEP. Do they not have IEPs because it's a special school, or?
I'm not sure, to be honest, and I could look into it. And
Yeah, no,
absolutely.
just curious.
They send to, so school districts can enroll their child, their students into this Michigan School for the Deaf.
Okay.
So they come with their IP from their sending district.
Oh.
So they come through.
Through their sending district to the School for the Deaf.
Okay.
So a parent can't just like send their child there, they would have to like go through their.
It's not a private school,
Okay.
right? But I'm sure the state would take cash, so yeah, maybe they could. I don't think, but typically that's not how it happens.
Well, that's why I'm wondering about the OT and PT.
Right. Wouldn't
those
that
other
come with it, or do they-
Services that are not
Right.
being provided.
Think about any center-based program. You know what you sign up for,
Right.
right?
But
Yeah.
legally,
Well, that's a different conversation.
That's what I was thinking too, like if it is, like in
Right.
the public schools, children have the right.
But
for
because
those
if that's what I was
services.
thinking too, if it's public, because it is different if it's a private, then
Right.
you're right, you choose to go there. You
It's
choose
interesting
knowing.
what more Brittany has a chance to learn. I mean, you've been working there for
I've been
about
there a
5
month.
weeks.
Oh, okay. And we're grilling you, sorry.
who see them in the classroom every day. So you need a full hearing test, full speech and language evaluation, a psychological evaluation, and sometimes they even do imaging for these patients and other more sophisticated testing, but there's no gold standard for how to test these kids. So all treatment depends on the kid because there's a lot of additional things going on. So really, it's just based on their needs and where they're having difficulty. So you can do personalized therapy sessions with speech-language pathologists, really working on distinguishing between those different sounds in speech and kind of giving them tools. But also there are some online training programs that are kind of doing the same thing. But it's really working on presenting sounds to one ear and then the other ear and then both ears at the same time and working on the integration. Then you can also use FM systems in the classroom. That's been proven to be a really good way to help these kids with APD because you're putting the teacher's voice or whoever's speaking directly into their ear, and we know that that helps minimize any of the background noise and really give them the best access. But can't go wrong with good communication skills. So this is a lifelong problem. Most of these people have it their entire life. And so really giving them skills and tools about how to self-advocate for good communication skills and what's best for them is really necessary for them to succeed. So it is a lifelong problem, and some of these online training programs are made for kids and adults, and it kind of goes both ways. So there's quite a few resources. Like I said, this is APD is relatively new in our field, and there's no gold standard for how to test. There's really no gold standard for treatment. It's all based on each individual. And I really want to emphasize that because at this point, we don't even really know exactly how many people have auditory processing disorder. So it's an evolving condition that we're trying to work with now. That's that. Did I do it in 5 minutes?
Under 5 minutes.
Yay!
Time for questions?
So time for questions. Sorry, that was really quick. Yes.
So I was wondering, because I deal with a lot of families through my job at the Family Center, and a lot of times you may have a child that's in early elementary school, and they're noticing these issues, but they're not on an IEP or a 504, and they don't really know. Somebody's telling them, you have to do a reform or request to get evaluated in school, but I mean, can't they go outside of the school system? Where would I refer families who may have some type of either auditory processing disorder or something else that may be similar, but they're not quite sure what's going on?
Well, when I've seen the referrals in the past, it's come through the pediatrician, and they usually see psychology and audiology at the same time. Because, like I said, we kind of have to put both of those pieces of the puzzle together to really understand. Because sometimes we have to tease out, is this an attention issue or is there something else underlying? So I've only ever seen it from
a pediatrician. Yeah, there was a particular family, and I had asked the same question. What about your pediatrician? Well, they don't really, they said they don't do that. I'm like, that's not anything that I understand. So I might maybe need to.
Because I've seen a couple cases that come in, and we've identified
So I think that a
normal
pediatrician
hearing.
would at that point.
Right. But instead, they just had an audiology referral, and from there we could kind of take the steps. Like, we know the hearing is normal, but we're not going to discount these problems that you're having. And then we can also, there are certain resources that we can refer to do that additional testing. The testing takes a long time.
Right.
It's many steps and very lengthy. So it usually takes multiple appointments, and only certain places do the testing.
And I wonder if insurance is paid for it.
I don't think they do.
Oh,
They do
okay.
not.
That's one of the challenges as a
That is a challenge.
pediatrician, is I to refer you, but
It's very expensive.
It's very expensive. I mean, even for adults, it's like 2 hours of your time, and it's just
I didn't think about that.
constant speech testing. Yeah, so it's exhausting.
I was just going to ask, my son actually has auditory processing disorder. We got him evaluated after he received his diagnosis of ADHD because we could still tell there was something going on.
Something more than just
Right,
attention.
right. And it was hard for us to figure out, where to go and where to navigate those next steps, because a lot of times it was like, well, maybe the school could test his hearing, and people just understanding that this necessarily wasn't a hearing problem, it was a processing, and and so my question to you is regarding neurofeedback. Did you find any information or success with auditory processing disorder and utilizing some of those online programs or computer programs?
I mean, I didn't really, Jamie, do you have anything to add about that?
I would just say that there is very little evidence that the programs that you can buy are effective.
that's helpful to know, because as a pediatrician, I get asked about, should I spend $500 and buy this program? And so it's, my hunch has been, I haven't seen anything to say that it is effective, but I can't tell you that isn't, but maybe, so that's helpful to
Yeah.
know, for all of us, not
From
just
an
as a
evidence-based
pediatrician.
approach, there's not sufficient evidence for professional associations, for example, to
Endorse those.
say that.
Well, I know when I was doing my research, I mean, some of these programs through different organizations, I mean, it was like $2,000, $3,000, and it's like, okay, so I was looking for some of that research and trying to see if there was any, evidence-based, related to the success. So.
My question was very similar to that, and that is, are any of the interventions proven to be efficacious? And how do you actually evaluate ongoing whether the interventions are working? Because this is such a complicated
It is very
process, and you
complicated.
need something that's an ongoing evaluation.
Right, and you can, repeat testing after some form of intervention and kind of see if that integrates, because what it is for testing, it's testing speech, understanding, and noise most of the time. So most of the time, children have to be a little bit older to be able to do these tests in the first place. But then it's sending the sounds into one ear versus the other ear, and then both ears together. So you can evaluate that and see if they're able to differentiate between these sounds a little better. But it's mostly just like having evaluations from speech-language pathology showing any kind of progress. But you're right, it's very complicated.
So my condition I chose was chromosome ring 9, and I'm going to refer to it just as ring 9, just so you know. So chromosome ring 9 is a rare disorder that occurs when the 9th chromosome forms a ring during the early stages of development within the embryo. So chromosome rings can form in two ways. The first is when one or both ends of the chromosome break off and they fuse together. And during this process, genetic material is lost. And then the second way is just random. So formation can occur randomly during the cell division process. So there's only about 30 reported cases within the literature. There's no identified risk factors, and prevalence hasn't been established within gender, racial groups, or ethnicity. So associated effects range in severity depending on which genes were lost or replicated during during when the chromosome formed the ring. So what if any genetic material was lost. Cognitive features include intellectual or developmental disabilities, communication and speech language disorder. Epilepsy is a common neurological disorder that's associated with chromosome ring 9. Facial features is a keel-shaped head, microcephaly, which is like a smaller than average head size, high cleft palate, receding jaw, and upslanting or upward angled eyes. So physical features of individuals with chromosome ring 9 usually are short-statured. They have a spinal curvature. Low muscle tone is a huge feature. Cognitive congenital heart defects, excessive facial hair, and hand and foot abnormalities. So ring 9 can be diagnosed prenatally through an analysis of the the fluid in the embryo, but it's typically diagnosed after birth, and it's done by a multidisciplinary team through clinical evaluations through specialists. A geneticist would be ultimately determining if an individual had ring 9, and that's through a FISH analysis, which, from my understanding, is it's basically maps out a person's genes, and they can determine what genes were affected. And this is important because through the FISH analysis, you can figure out which genes were lost during deletion, which is when some genetic material is lost, so they can determine what effects would have on that person. So surgery may be needed to correct any congenital abnormalities, such as like head and with the low muscle tone as well, and heart defects. So early intervention services are very important. This is because a lot of individuals with Ring 9 experienced a lot of developmental delays. So special education, speech language services, physical and occupational therapy, because low muscle tone is very prevalent. And then families and individuals with Ring 9 face a lot of unique challenges of having a rare disorder. One would be misdiagnosis. They experience a lot of misdiagnosis. There's limited or no information about what to expect. And they also oftentimes face problems coordinating and financing multidisciplinary care. So the families can oftentimes benefit from family support networks, like the National Organization for Rare Diseases, and there's also a specific chromosome network too. That's it. Any questions?
Yeah, go ahead.
Are there known familial risk factors? In other words, is this something that only a certain family with its genetic history would screen for? Or is this something that would typically done in prenatal amniotic testing for a wide range of chromosomal abnormalities? I'm trying to figure out what are the risk factors and how do you, because it's so rare.
Yeah, that's what they were saying, that there isn't, like, even if you do have the gene or you do have some in your family, it doesn't necessarily mean that you carry any gene for it. So from what I understand, it seems random. Do you agree, Jade?
Well, I've never heard of it before,
Okay.
so I was going to say, when I first saw that you were doing Ring 9, I'm thinking, oh my God, I've never even heard of this. But then when you showed that it's like 9 people have been reported, or 30 people,
yeah.
30 people.
So my interest in it came because I worked at a camp, and we actually had 2 campers with Ring 9. So just from a stats perspective, I thought, well, I know like 6% of the population.
Wow.
So
Amazing. I was wondering how you, where you heard of it. So you
And it
actually
was-
met some kids with it.
Yeah, it was interesting to me because the effects were super different from child to child. One of the children who I know with Ring 9, she is nonverbal. She uses a wheelchair, and the other child is completely the opposite. So that was really interesting. She speaks up a storm, and so it was just really different. That's what I was kind of thinking. So it was almost like CP in my opinion, that I was like, wow, there's so much variation.
Yeah, fascinating.
Yeah.
Do you think those differences are due to kind of like an early intervention?
It could be. A lot of it is within the chromosome. So it's if they lose genetic material, that affects the symptoms.
But you mean early as in therapies or what?
Yeah, so you have 2 people with the same kind of genetic issue, but one of them's can't walk and talk, and the other one's verbal, and I'm wondering if that's kind of OT and speech things that are just got caught early enough where they could develop it later on.
Yeah, most definitely. That would definitely be an issue. Because low muscle tone's a big thing. So if they use AFOs and have the right services, that could definitely impact their down the road.
I know.
Yes.
I had never heard of keel-shaped head.
What is it?
Is that a common term? Keel-shaped head?
There's a specific term. I didn't know if I was saying this right, guys, so I'm so sorry, but it's the top one, treble.
What was his keel of work? I don't know what it is.
So we've been Googling it over here. Like the consensuses were like, what is that?
Well, the keel of a ship.
Keel of a
above it,
ship.
So it's got a specific shape to it.
Oh, like
What the scaffold kept giving.
It's a rounded triangle shape almost.
I'm sorry, if you said that to
Keel, that's what a keel is.
almost like a cone, kind
Yeah,
of.
well, yeah, in a way, yeah. That's the thing I thought of. I've never heard the term outside of
Everyone
that.
said keel-shaped head. I thought that was normal.
God, it's all something. That's not normal.
Disability. Has anyone heard of that before? Okay, great. It's almost a misnomer because people that have NVLD are very verbal. This is actually their strength. It's what they excel at. And I had a teacher tell me one time, I've got a student, I think they might have NVLD. They haven't spoken in days. So it's not quite that. It's not selective mutism. It's a student who has a strength in written or verbal skills, and they have the deficits in other areas. And so sometimes it's called NVLD, sometimes it's called NLD, right? There are weaknesses in social communication, mathematics, senses of direction, weights, telling, how heavier something is than something else, being able to judge distances. So if you stand over there, for instance, and you tell them to throw the ball, they might only throw it halfway in the room, or they would overthrow it significantly. So just being able to judge that distance is very difficult for them. So their strengths, verbal expression, they're very good spellers. They have high vocabulary. In early elementary, they tend to be above grade level. They're able to concentrate for long periods of time, so they can sit there and do their work for hours on end. Most of them, there's some exceptions to that. Strong reading and spelling. They might be the best speller in the school, win the spelling bee. And typically they have above average intelligence. So the major problem for these students, the communication and comprehension, right? So just because you can read well, or it sounds like you're reading well, doesn't mean that you understand what you're reading. So you might be able to decode, you might be able to say the big words, but you have no idea what you just read, right? And so the sad thing for these students is that teachers think they're lazy. They look at these kids and they say, well, this guy, he's got a high IQ and he sounds intelligent. So what's the problem? Why are they getting these bad grades? Okay. Some of the weaknesses, social skills. So it looks a lot like autism, right? When you look at some of the social skills, you look at some of the awkwardness in social situations, physical awkwardness, bumping into things, clumsiness. So it looks a little bit, or actually a lot, like autism. Difficulties in math, poor handwriting, comprehension, coordination, and we discussed estimation of weight, size, and distance, and spatial perception. This is the major weakness. They're not visual learners, so they get lost. They're not good at maps. They could leave out the room and go someplace and then forget how to get back quite easily. Okay. Are they the same? We used to think that NVLD was the same thing as Asperger's, right? Mainly because of the social interactions. It's difficult for them to get to social clues. They might stand right next to you when they're talking. You may have to go, you gotta leave in 2 minutes, and the person doesn't recognize that, and they keep going on and on and on and on, and they just don't get those cues, right? So a lot of times it looks like autism, but there are some distinct differences. So eye contact is a problem. Depression and anxiety is an issue for them. Literal thinking, awkwardness, social relationships. But the differences are people that have Asperger's, they're very visual people, where the people that have NVLD, they're very auditory learners, right? So the person with Asperger's, they're good at seeing the details. They can remember what you had on, 2 months ago, right? They can remember how they got someplace. But the NVLD is the exact opposite of that, okay? People with Asperger's, they do repetitive behaviors, they have rituals. People with NVLD typically do not have non-functional rituals or repetitive behaviors. You've got math and computer strengths in Asperger's as opposed to literary strengths in people that have NVLD. And I'm almost done. And so in terms of diagnosing this disorder, it was recently discovered about 20 years ago. It got into the literature, so it is not in the DSM-5 as of yet. But it's important to understand that the disorder does exist. It's well established in academia and among researchers, so that we can kind of adapt how we instruct these individuals and help them succeed better in their academic endeavors. And then common strategies, I'm not going to have time to go into common strategies, but basically the main thing with them is helping them generalize situations and not assuming that because they have some strengths that they have strengths in all areas. So just because they're able to speak well and they sound intelligent doesn't mean that they're able to do certain activities that calls for independent thinking, that calls for critical thinking, that calls for comprehension. So they have strengths in certain areas, but they also have very distinguished deficits. So it's important to understand that. And the last slide is the impact in adulthood. The average person with NVLD is diagnosed at 13 years of age, so this is very late. And the reason is because they're very verbal. And so in elementary, they tend to do very well because most of the elementary school is memorization and regurgitation. So yeah, they can memorize things. They hear it one time, it's in their head. They have very good rote memory. So math, facts, whatever type of vocabulary you throw at them, they're good at that. But as they get higher in the grades, they start to do worse and worse. And people can't figure out, what's going on. High IQ, they're getting A's in 3rd grade, now they're in 4th grade and 5th grade, and they're starting to fail, so they must be lazy. And so I'll stop there. I think my time is up, and I'll let you guys ask questions. Maybe I can talk more in the question and answer session.
Very good.
Yes, ma'am.
Hi, yeah, so I have a question, and I don't know if you can answer it, but so when I was doing a lot of diagnostics, I, would run into this and very rarely diagnose it, but I know on our psychology team, we would go back and forth all the time about how to categorize it, given that it's not in the DSM. Is it a cognitive disorder, or is it a learning disorder? I know, honestly, we went back and forth all the time. Nobody could figure out what we should call it, how we should code it. I don't know if you came across anything where people talk about that.
My personal opinion would be that it would be more towards a learning disorder when you look at the fact that there's such a discrepancy between the IQ and the achievement, and that's the main thing that you're looking at.
Yeah.
Yes, ma'am.
Do you know if there's any physical manifestations?
Physical manifestations, other than awkwardness and clumsiness? No, ma'am. It's hard for them to do simple things like jump rope, especially when they're between the ages of like 9 and 15. By the time they get 15 and 16, they kind of catch up on those skills, but they're behind their peers. So, they could just be running and they'll put one foot behind the other and trip on themselves and just simply running in the, in the gymnasium or something like that. But the thing about it is there's no very profound manifestations in their behavior that you would know that they had NVLD. And so they're diagnosed very late. Meaning most of us that have NVLD, they don't get diagnosed. And so they just go through life suffering, and that's why they're more prone to depression, because people, they can't understand, like, you have all these gifts, you have all these strengths. Why are you not being successful in work or in academia? Yes, sir.
I'm really interested in why or how they have above average IQs if they're so heavily kind of right brain deficient. I know I saw in there like dyscalculia, they're not good visual learners. I'm wondering, is their VIQ just so vastly like above average that it outweighs their deficiencies? On something like the whisk, or you can still give the whisk?
Maybe someone else could better.
Those are heavily verbal, though. Like a lot of the IQ tests are heavily verbal. So if you're a good speaker, you can talk your way.
Like block design.
Right. Well, that's how I would diagnose those purely nonverbal tests would be significantly lower, but the verbal stuff, is usually really high. But a lot of the traditional IQ tests are heavily verbal.
Yeah, they blow it out the water on the IQ test because their vocabulary is expensive. Pretty much many or the majority of the words that they've seen and they've heard, they're going to memorize those words, and they're going to have those in their head. And sometimes they're kind of isolated and withdrawn, So they're very extensive readers. So they'll sit there and they'll read all day and they have that ability for concentration. So they might be in a book for 7 hours or 8 hours a day. So they typically do well on those type of tests. But if you give them a test that kind of like in an essay format, where it's not just, okay, match the definition, what's the opposite of this word, what's this word, and you ask them to kind of do some critical thinking, then that's where the problem lies for them. But traditional testing, they usually do very well. Yes, ma'am.
So if somebody was going in for neuropsych testing or whatever, maybe they have no clue, never heard of this or whatever, do many people get misdiagnosed as other things, as ADHD, as other conditions? Yes. How do they, I guess I don't understand, how do people get a good diagnosis if this is actually...
They don't, and this is the problem. You don't catch them.
Okay.
Especially in the early grades, because the questions that you ask, so they're very verbal, they do talk, but a lot of things that they say don't make sense. So when you watch them play as youngsters, you'll find them going up to other kids and they're talking, but they're saying random things, or they're talking about random things that have actually nothing to do with the play. But you'll find them talking, right? They won't be, isolated to themselves. So when you go for an assessment, typical questions will be asked about the developmental milestones. Well, were they talking at this age? Yeah, they were talking before average age. Well, how about their reading? Well, they were reading before normal kids. So, because that's their strength, so they have to rely on that to have any understanding of the world. It's kind of like someone that doesn't see. So their hearing skills are very attuned because they have nothing else to rely on. So, yeah, it's very difficult to diagnose.
I often wonder, maybe do they have any kind of depth perception issues as well?
Yes.
Oh, they
From the University of Michigan School of Dentistry. I'm a third year dentist student here. I'll be talking to you guys about Tourette syndrome today. So the commonality between all these people and me, besides our good looks, is the Tourette syndrome. I was diagnosed when I was 6, and I was re-diagnosed at 25. The etiology is really mostly hypotheses. There's a lot of postulations about the possibility that it may be autoimmune driven, genetic contributions, and that there's neurotransmitter transmission abnormalities. But at the end of the day, there's an abnormality in the basal ganglia of the brain, which is at the sort of essential core of your brain, and that it can present in many different ways. The most consistent finding in every individual with Tourette's is that they present with varying severity of tic, and I think most people here are aware of what it looks like. Yeah. Epidemiology is it's relatively common. It's about 1 in every 100 people. It can last a lifetime, and a lot of people grow out of the tics, but I haven't, and these people haven't either. Notice how I put everything for David Beckham. I have like 3 of his autobiographies. I play soccer, so him being a great passer is like he is an idol of mine. Okay, so back to the task at hand. So I have a little clip of Tourette syndrome that tics look like, but I think most people know what it looks like, so I'm going to skip that part. Excuse my language of saying comorbidities. I think I should have titled it concurrent conditions. A lot of times tics are suppressible. That's something that I feel like is always going to be one of my biggest accomplishments in being able to suppress it as well as I do. I've spent a lot of time in front of the mirror just by myself, and I know, I think that's sort of become such a big part of my life where through self-training I had to be very relatively self-aware. I had to spend a lot of time on my own. I need that alone time, and so I think when I started dating my current girlfriend too, I had to tell her, if I do these things, just tell me to breathe, because usually that's what my mom tells me. When she hears me go, on the phone, she just lets me have it, have like a minute or so just doing my thing, and then we continue our conversation like it never happened. So a lot of times these tics present with obsessive or compulsive behavior and attention deficit, and learning disabilities like dyslexia. I did have a lot of trouble reading when I was growing up, but I don't have that trouble as much now. And 5 to 15% of Tourette syndrome also present with a spectrum on the ASD. There's no clear diagnostic tool for Tourette's. It's largely based on observation. And I remember going through a number of different therapy sessions when I was younger. They would put me in a playroom and then see how I react to different stimuli. And through those activities, I think I've become better aware of how I respond to different emotions. So that really helps. And sometimes, even in social settings nowadays, I have to take a moment and sometimes people think that I'm getting moody, but really when I'm not talking or something, I might be fighting that urge. Treatment. A couple of medications that I was on when I was younger, they I think are usually used to treat like ADHD. Unfortunately, there's not a good medical intervention to treat tics or Tourette's in general. For me, the side effects were more visible than the therapeutic effects of the medicine. So, my mom would describe, thinking back, she would say that I just looked like a really intoxicated kid. I would go around I would get up in the middle of the night and, go to the front door and start peeing or something. So when I was re-diagnosed at 25, I had to do so. I had to get a re-diagnosis so that I can maybe consider different types of medications to treat my symptoms, because what happened was my tics moved from being vocal more towards being motor. And around 25, I think I developed a new tic where I kept on exhaling without inhaling. So my diaphragm will continue to pop, and a part of my OCD kicks in, and I begin to think that basically when you get a tic, the only way you can stop or feel comfortable stopping is if you feel the relief from expressing. And the OCD kicks in and thinks, I can't stop. I have to continue doing it. So that's why. So then I would get severe dizziness and fatigue from continuous exhalation without inhalation. So as with a lot of other disorders in children, I think parents often feel guilty for not being able to do any more than they already are for their children. I think it's really important for people like me that can communicate these things. I think it's really important for those children or the patients to have an open conversation with their parents about these things. They don't always come up with me and my parents, but I try to, whenever it does come up, I try to have a conversation, let them know that it's not debilitating. It doesn't affect my day-to-day life. I just take it as it comes, and if I have to react to a certain emotion or a situation, I choose to do it in a certain way so that sometimes I'm not viewed by others in a certain way. So if I'm mad at something, if I don't react to that anger, then I'll expose myself. I will have this bouts of severe tics. So then I have to choose to let go of that emotion and just be angry, as opposed to trying to hold it in. So I think a lot of times parents also notice that when their kids come home from school, they sort of let go and show more of that symptoms. And that's been exactly the true case for me as well. So whenever I come home, sometimes I have to sort of lock myself in a room and do my thing, or things of that nature. Yeah, so this, I've already addressed this briefly. Acceptance, no diagnostics, clear diagnostics tools available for post-Tourette syndrome, but what clinicians can do, not even just clinicians, but I think in general in the society, I think what people can do is be a little more accepting. I think, okay, for me, I think the way I viewed myself when I was growing up, I think the societal response to how I would react to a certain situation sort of shaped me pretty heavily, because I grew up until the age of 14 in South Korea, and you know, it's a pretty conservative traditional society there, and so, you know, being that tics aren't necessarily, it's only visible, and it's strange for people to see, right? It's abnormal. So then my peers and elders would say, would consider that my symptoms as sort of a bad habit, and they would just simply order me to stop, right? So that, I think that sort of shaped me to view myself in a certain way growing up. Those are my references. Questions for me?
I have a question.
Yeah.
Did you notice, and you said the re-diagnosis, so the medication, like the variety of choices or considerations of medication, had it changed a lot since your initial medical intervention of, you know, medication back to when to now, what, later when you were 25?
Yeah, I think so. I think there's more variety, but I think they mostly belong under the same umbrella, class of medications.
Okay.
I think what I had mentioned was they all treat symptoms of ADHD basically. And for me, I've tried a couple of different types, and they don't really do much for me other than side effects. And sometimes it's funny because side effects worsen your tics. And if you're taking, I think I mentioned it in the slides earlier too, if you've been taking for a prolonged period of time, then you have to be really careful about coming off of it, because if you do it too suddenly, your symptoms are going to mushroom. Or you might have withdrawal symptoms from that.
Did you try any chemotherapy?
No, that's not something that was made available to me. You know, I didn't know. I was already an adult when I got here, and yes, you know, I didn't really know anything about that growing up. The few times that I remember being in therapy was when I was really, really little. Yeah.
Do you know if it's kind of the same malfunction for motor and vocal tics? Like, we know basal ganglia involve like initiation of motor movement. Is it the same kind of pathway or circuitry that you have?
Yeah, so basic science, etiology, I'm not too familiar with, but what I do know is that when the symptoms arise, at first I don't know, and I only know by observing myself. And the good thing is that for me, you know, I've tried to master this on my own for long enough of a time that even before the first sign comes up, I can notice it and I can try to fight it. You know, I don't know about the signal pathways so much. Yeah.
You kind of answered that right there, but do you know kind of what your triggers are?
Yeah, when I'm...
Are they random?
Yeah, well, they're not, they're pretty consistent. They're, when I'm really upset, sadly when I'm also very happy. So like, you know, extreme ends of the emotion, they trigger. And even when I'm really, really comfortable, sometimes you know, when I'm by myself though, I just have to let it go. I just have to, you know, I try to train myself looking at the mirror, but even when I'm not amongst other people outside, like at first when stepping out the door was it was a task for me, because you know I had to constantly restrict myself. But you know, even today, sometimes like when I'm just by myself, I still feel like I'm being watched. I'm in front of a mirror. So when I feel that kind of suppression, I try, you know, that acts out.
I just want to thank you so much for being up here and opening up to us, because, I mean, I would have never known at any time, but I think that just, you know, that's great for, you know, for you to be able to be open, because that opens the doorway to acceptance and hopefully helping you to feel more comfortable around all of us here as well. And I learned a lot. We actually were at a conference, it's called the Michigan Council for Exceptional Children conference like 2 years ago. And there's a teacher, is anything in Georgia?
Somewhere down
He's in
south.
Georgia. His name's Brad Cohen though. Yeah. And they did this old ABC family movies that they used to do, like the after-school movies that probably all of you weren't even born back when they used to do these.
But it's on YouTube.
But it's still on
The
YouTube. It's
movie's
called Head
on
of the
YouTube.
Class.
It's a great movie.
And it's about his life growing up with Tourette's and just really horrible things, but it turns around as he has this one amazing principal at the school that really just, and he ends up becoming a teacher, and just it's a really great story.
He's a great advocate and does, you know, presentations and just conferences around the country and I think internationally as well. And yeah, so front of the class, Brad Cohen, great
Yeah,
advocate.
look it up. It's very inspiring.
Is that all?
Good job.
I just actually learned about ectrodactyly on Wednesday when I went to have my meeting with Dr. Nuckins, so there might be those of you out here who know much more about it than I do. Anyways, the other name for it is split hand, split foot malformation, or you might have heard it referred to as lobster claw hands, as you can kind of see from the pictures. So it's a congenital limb malformation. It's characterized by the absence or deformation of one or more digits of the hand or the feet. And it often leaves these clefts, these median clefts that are U or V-shaped in the hands and feet as well. Another characteristic is aplasia or hypoplasia of the phalanges, metacarpals or metatarsals. And then the remaining fingers always have syndactyly. So they're kind of like webbed together or bones are fused together into one. You know what I'm talking about. Prevalence, it's estimated about 200,000 people have it globally, and incidence rates lie between 1 in 10,000 and 1 in 150,000 births. So huge range there. I kept trying to find like a more accurate incidence rates through the journal articles, and all that I could really come up with is that there's over 150 limb malformation like disorders. So whether or not it gets characterized as ectrodactyly or one of the others is kind of just up in the air. It does affect males and females equally. So we kind of had a little genetics class earlier. It's autosomal dominant, so you only need one of the mutated genes in order to express it. So if you have this disorder, you have a 50% chance of passing it on to one of your children. It's associated with aberrations in chromosome 7 between the Q21 and 22 region. I didn't do as good a job explaining that as Kayla did earlier. But there are 4 other genetic foci that have been like found, and it's just we don't really know which ones lead to it. It's also X-linked recessive. So in this case, if you have a mother who has a disorder, she has 2 X chromosomes. She can give one of the unaffected to a girl, and then she could also get another unaffected X from her father, and she won't have it. But if she gives her X chromosome that's affected to the boy, then he's going to get his Y chromosome from his father, and he will always express that. So it's manifested in 2 different ways. It's either isolated or syndromic. Isolated, it's typically just in the limbs of the hands or the feet. But in syndromic, it can be in the hair, the teeth, the nails, and it often comes accompanied with sensory neural hearing loss and mental retardation. And I think that's how we got the patient in your clinic. That occurs in about 5 to 29% of the cases. Like I said, it's not a really good number, 5 to a quarter, but it's kind of all we have. Really, it's diagnosed at birth. It's kind of hard to miss, you know, syndactyly of the limbs, and that's kind of the main thing that they go for. And then the syndromic versions can either be clarified through genetic testing at that chromosome 7, Q21, 22 region. And then as subjects age, you know, neuropsych and audiological testing are really going to be what screens for mental retardation and the sensory neural hearing loss. So treatment, it's extremely invasive. Usually it just involves surgical detachment of the fingers, separating them. Sometimes if the bone structure is really, really malformed, we'll have to put in steel rods and then expand the fingers that way, so you can see in the picture. So as you can imagine, this kind of fits every single discipline that's in this room. I mean, you have physicians and surgeons that are going to be working on that at birth. It can be seen in sonograms, in a pregnancy. Psychologists are going to help screen for the cognitive impairments, audiologists for the hearing. genetic counseling is going to be really big because you really want to know what are my odds of passing this on to my child, and what are the other hardships and everything that come with that. Speech language pathologists are really important because it's often accompanied with cleft lip and cleft palate, so you might have to learn how to speak differently as well. And then dentists, because when it happens in the teeth, they're really, really malformed jaws. And there's a lot of work that needs to be done so that they can talk, eat, and chew right. So things to consider, everyone views disabilities and symptoms differently. The majority of people, we just don't know kind of what's out there, what options are available, and how to treat it. With a 50% chance of passing on to your offspring, you kind of really want to see like, how is this going to affect me? How is this going to affect my family? And is this fair to pass on to my child when they don't have a choice of whether or not they're going to receive this disorder or not? So even without mental retardation and the sensory neural deafness, you can imagine that there'll be a lot of developmental issues, anything pertaining to posture, balance, fine sensory motor coordination, socialization. When you look different, people are going to treat you different, and you don't have the same social interactions growing up developmentally. And then, of course, communication based on the cleft lip and palate. And that's all I got.
Yeah, as you were talking about this, I was reminded when I was undergrad, I watched a short documentary about a woman who had this disorder. And I wish I remember the name of it, but she was a news anchor. And I remember her first producers made her wear prosthetic hands, so she would show her hands on camera, but she campaigned to show her natural hands. She was able to eventually do that, and then through the course of her being an anchor, she got married and had children, but yeah, I remember some of the viewers were incredibly cruel to her because they thought it was so selfish that she decided to have children. Yeah, because she could have passed that on. She did. She had 2 kids.
Well, we're gonna compare notes.
There's lots to know.
Who's the expert?
It's okay.
Yeah.
You know.
So as Abby told me, so Down syndrome is when an individual has an extra copy or a part of the chromosome 21. She did state that trisomy 21 was the most prevalent, and there are also 2 different kinds, translocation and mosaicism. Trisomy 21 is responsible for 95% of, there's 95% that are that type, and the other 5% are the other 2. And that has to do with, the other 2 have to do with having parts of the chromosome, or not all cells having the parts of it. So it is recognized by, firstly, prenatal screening can do this, so blood test and ultrasound. Blood test shows genetic markers, and, and then ultrasound shows increased fluid on the neck. But that does not mean that they have Down syndrome. It's a good indication. And then going forward, they can do a diagnostic test through amniocentesis or other 2 tests. One is through the embryonic fluid. One is through, I can't remember what chorionic villus is, but percutaneous is the umbilical cord. And then after birth, it's based predominantly on physical signs and then through a blood test. And the physical signs, as you know, are the crease in the hand, the facial features, which are outlined here, and also a space between the big toe and the next toe. And the second guy is my second cousin.
Aww. Well, how old is he?
He passed away last year, but he was 62.
That's a good life. Yeah.
So, as Abby also said, heart defects are very prevalent in people with Down syndrome, and that can be taken care of very early on, and they have a good outcome after that. My cousins also had a daughter, different side, that did have a heart defect, and that was years and years ago, so it was not a good outcome. But now that has a very good outcome. Also, the other problems that were outlined, respiratory problems, hearing problems, dementia, Alzheimer's, leukemia, and thyroid conditions. It's one of the most common genetic conditions. 400,000 Americans have Down syndrome, and 1 in 7 or 800 babies per year. It's not just one race, one economic, it's anyone it can affect. There's a higher chance, I found, with an older mother
and as many as 80% reach 6 years old, and like I said, my cousin was 62. Basically, as far as treatment, just inclusion, just support, everything. They can do whatever they set their heart to. This young man down here in this picture was a manager, an owner and operator of a restaurant. And this is in Albuquerque, and he greeted every customer with a hug. That was his thing. So come to Tim's Place for a hug and a good meal. And he would be out there with his customer service and how's your meal? Do you need anything else? So he actually owned this restaurant with assistance from his parents as well, but he was the one operating everything. So there's a model that's well known on the bottom right corner. And you know, inclusion is the big thing with Down syndrome. Physical disabilities, cognitive disabilities, and life expectancy are some things that are altered for people with Down syndrome. Siblings can learn a lot from kids with Down syndrome. They just learn different skills that other kids don't understand because they're exposed to that so early on. As far as families, parents and other siblings and everything need to care for themselves and just encouragement and love. Some things that are disparities with Down syndrome, some healthcare professionals aren't very accepting sometimes. They don't have the expertise, they don't know how to meet the needs of people with Down syndrome, so they don't accept that. And so they aren't seen for routine exams, dental exams, physical, stuff like that. Education, advocacy, and funding are kind of low. And one interesting fact that I found was African Americans have a lower age at death as 25, and Caucasians are 50. So I just thought that was interesting.
Ew, wow.
Yeah, and it's, you know, they don't know if it's because they're not seeking care, because they're not, you know, they don't know. So I just thought that was interesting.
Oh.
So that's it.
Oh, that's coming.
That was great.
Is the age of parenthood seems to be going up and up? Are there increased concerns, increased prevalence of Downs? And it is interesting, by the way, you noted the age of mother, but isn't age of father a little bit correlated? But
Yeah.
not as much so,
Yeah.
Spermatogenesis is affected with aging also.
Yeah, definitely. I didn't really research as far as the incidence of that because the age of mothers is increasing, but definitely males, fathers as well. Yeah.
I just have a quick comment. It's so nice to see that that the maturity of our citizens with Down syndrome are living longer.
Yeah.
That life expectancy is really growing.
Yeah.
But I got to tell you, it is a great experience for anyone working in the field. One of the best learning experiences I had was going to a national NDSS conference, National Down Syndrome Conference. It's the only place where you see babies, literally just born, coming. There was a 3-week-old, the first conference I went to, and somebody in their 60s or 70s having that shared experience. But it was really important for those young families to see that very productive lives and fulfilling lives and long, long life.
Yeah.
Because when you're in your 3-week-old point, you're dealing with the cardiac things, and you're in the emergency room, and you're in the crisis.
Right.
So it was a really cool thing, but it also was a great thing that we have folks living a really long time now.
Right.
That's
and
huge.
moving from that institutionalization
Exactly.
to now such inclusion is
Yep.
amazing.
Yeah, I mean, just kind of, you know, piggybacking on what Angela said, you know, definitely as a parent when you're first thrust into this world, whether it's a prenatal diagnosis or, you know, at birth, mine was prenatally, but, you know, once I found this amazing support group online of families all over, and you look up to that, you want to know, you kind of want to know where they're going to be, maybe not too much, but you need to know that, oh, these families are happy, they're thriving, they're doing amazing, and, you know, it really just kind of changes your whole entire life. But it's, I haven't been to an NDSS conference yet, but I'm hoping to go next year.
And I don't have a family member with Down syndrome, so I really enjoyed it. So.
What was that?
Did your daughter have any handicaps?
She was born with a complete AVSD.
Okay.
She was operated on a little over 6 months. They wanted to do it at her 5 months, but she was hospitalized with bronchiolitis the month before for about 2 weeks. And she had developed, I had a prenatal diagnosis. I knew about the heart defect, but she had developed in my 32nd week a condition called non-immune hydrophytalis, which is they have a high mortality rate. And they put me in the hospital and gave me a very grim prognosis. And of course, at that point, I kind of accepted all this other stuff. And I'm like, none of that stuff, doesn't even matter anymore. I just don't want to leave this hospital without her. And she's sassy as I'll get out now. And you never know that she struggled, but she, it was scary.
I know, let's see, as people with Down syndrome age, they have like an 85% chance of getting Alzheimer's. But as they're developing, do you know if there's an increase in like cortical degeneration or memory issues that are seen at younger ages developmentally with Down syndrome?
Yes.
I thought so.
Yeah. Can you explain
Certainly.
What his question?
Yeah. Or do you want to explain your question?
You're professional here.
Essentially, that high prevalence of Alzheimer's disease as individuals with Down syndrome age. So this question was really, do you see memory problems earlier on than when they actually are going to develop Alzheimer's or not? And the answer is yes. You definitely see decline in memory on neuropsychological testing, attention, language, those kinds of things as well.
And related to that is the onset of Alzheimer's earlier at younger ages.
The typical population.
Yeah.
Right, but I think by nature of there being an earlier life expectancy, it's adjusted. Correct.
One other thing I did want to point out was my cousin had very large perceptual difficulties, and I did notice with Abby sitting down, seeing like just knowing where your body is in space is a big thing too.
So, my daughter has depth perception issues. That's the same type of thing, and I don't know that. I mean, she seems to have always had this, but I used to take care of another little girl who had Down syndrome, and they were only 8 months apart, about 2 and 3 years old, and she lived on this great big hill, and we had to go down the hill for the bus, and Sophia, she just went, boom, she was gone, and Chloe's like, ah, so I wonder, it's interesting.
And this will be the last question.
Well, go ahead then, Ismael. You asked yours.
Oh, sorry. We'll do more.
The buzzer's going off in her ear.
Because it's not just about people not accessing care. So for the
Right.
general
Frequency of health,
African American population has less access, not through any fault of their own, but just in terms of how healthcare is delivered, etc. That's one thing. There's lots of theories about why they have worse health than people, and it can be related to poverty, the stress of racism, and there's a bunch of stuff. So Denise White-Perkins is going to come and join us and talk about that.
You guys are using the same brain.
But that is an extraordinary statistic.
Yeah.
It would have been really easy for me to do something in my field like childhood apraxia speech or stuttering, just something I see a lot and have curriculum on. So I have actually never heard of this before I started doing research, so if I am incorrect in anything, please feel free to correct me. This was definitely challenging, but I wanted it to be a learning experience for me. So raise your hand at any time if I say something wrong or incorrect. So Angelman syndrome is a neurodevelopmental disability. It occurs in 1 in 12,000 people to 1 in 24,000. The statistics aren't accurate because this is being misdiagnosed very frequently. About 50% of children that are diagnosed with Angelman syndrome have an incorrect diagnosis. So that's really, really scary. So it's a genetic and neurologic disease. It's usually characterized by several developmental delays. So a lot of motor delays, they might see a lot of PT and OT, a lot of ataxia and coordination of movements, which I don't know a lot about that either, so my OT friend might be able to help me there. But most often motor delays, there are speech delays, so this is relevant to my own discipline, but I'll get more into that later. So there's just some characteristics about it: absence or near absence of speech, challenges with movement, learning disabilities, tremor-like movements, behavioral issues, seizures. I mean, there was a huge range of symptoms that came up when I researched it, but these were the most common. So I have a little video clip here, hopefully it plays, just so you can see how it presents. It does have a very finite presentation. So.
Probably just grab the mouse there and click it, yeah.
Okay,
Just
well,
go ahead.
you would see prominent chin, deep set eyes, a really wide set face, flat back of the head, and then a protruding tongue. So, I mean, if you get a chance, Google it. It is very easy to distinguish just by looking at the face. So, good to know for sure. Now, what causes Angelman syndrome is a little bit over my head. In speech pathology, we don't get a lot of neurology and genetics, chromosomal deficiencies and things like that. So I'm going to do the best I can again. So in individuals with 68% of individuals who have Angelman syndrome, this is what occurs. So we're typically born with 2 number 15 chromosomes, a paternal and a maternal. And on that number 15 chromosome, we have what's called a Q12 band. So in 68% of individuals with Angelman syndrome, this Q12 band is actually missing, usually on the maternal chromosome. But there are other causes. It typically does do with the 15 or the number 15 chromosome, but other deficiencies of the Q12 band. So it gets a little tricky to diagnose there as well because it's not a consistent across the genetics. So, which makes it tricky to diagnose, and then we end up with 50% being misdiagnosed. So. In terms of professionals that might work with these individuals, we have physicians and doctors, physical therapists, occupational therapists, speech pathologists. I know for my discipline, these individuals might use an AAC device if they don't have any speech at all. Difficulty with the musculature and actually producing the speech, they might have articulation errors in their speech. So that may be another reason why I would see them. And then the impact on the child and the family over the lifespan, just getting a correct diagnosis. I can't imagine what these families go through and having to get a diagnosis and seeing all these specialists and interventionists just to be sent in the wrong direction time after time. So my heart is with them. I can't imagine what that must be like. And then having delays across developmental domains. So not only do you have to coordinate with an OT, a PT, a speech therapist, there's just so much that goes into it. Regular routine visits with all these professionals. And then you have to think about insurance. Insurance doesn't always allow for you to get all these services at once. Or they say you get this amount of time and services across PT, OT, and SLP, I'm sure you know. That's really hard to coordinate and obtain all the services these child might need. Financial challenges that go into any disability, especially with having so many interventionists. It would be nice if you had great insurance, but what about the people in rural communities that don't have insurance? Or, and then that's all I have. And I know Sharon was just getting ready to cut now. Like I said, I did the best I could. It was definitely challenging to do something I had never heard of, but I definitely learned a lot. Were there any questions that I could hopefully try to answer?
I just want to comment, the way that you explained the genetics was fantastic.
Yeah.
Yes.
I have zero background in it, so I really have to rely on my note cards.
I mean, I'm a pediatrician and I have some background in genetics and I haven't heard it explained so clearly, and your picture helped a lot too. Thank you, that was really well done.
Thank you, I appreciate that. I was worried about the questions.
Any of the professionals?
Yeah, anyone want to chime in on anything that I missed or that people should know about Angelman?
It's too bad the video wouldn't play.
I know,
That was really
it was
good.
just like a 1-minute
Yeah.
clip of kind of what these individuals look like, but it's definitely interesting, yeah.
So with all the misdiagnoses, how is it correctly diagnosed or identified?
A blood test. Let's see if I have anything. For 80 to 85%, a blood test can be done to identify whether the gene is working properly or not. For the other 15 to 20%, you need an experienced clinician who actually specializes in the disorder. So hopefully you're one of the 80% that the blood test works for, but that's not always the case. So.
And is the blood test actually have to go to a geneticist though to get that
I don't
done,
think
or-
so. I think it can just be referred on by a
Through a
physician.
primary?
Yeah.
So it's not like a genetic test where they send it off and get like a
Nope.
full.
Well, I think it probably, if I were to order it, I probably would have to know exactly what I was looking for.
Right.
So I
Right.
think
And
it's
that's-
more
it's-
often ordered by a geneticist who we know is
Starting
rather
to
than-
look.
Yeah. Now, that may be changing as there's more, broad exome analyses, but I think at this point, I would need to know what I was, please look at chromosome
Right,
15.
right,
And look for
It's
a
just not a common thing.
deficit in Q12. So I'd have to know what I was doing, and
That's why it usually takes so long for these people to get.
Yeah, I was gonna say, there's such a delay.
20,000, so.
Yeah.
To get into a geneticist in our state there's an extremely long waiting list.
And then once you get the diagnosis, to get
That's a-
services and have someone that has at least some sort of foundation in this disorder to know where to send you or what to do. You can go to the Angelman Foundation website and they have like a little search thing for clinicians in your area. So that was kind of cool. I searched my hometown in the Upper Peninsula and there was nothing nearby. So I just think about all those people up there.
Interpret this assignment in many different ways. So you could take a scientific approach to it, but I kind of took a personal approach to it. So I hope you can kind of hang with me on that. Everybody can close their eyes real fast. What if you wanted to say something to your brain, what if you wanted to say something to your brain and you told your mouth to say it, but your mouth didn't hear your brain? Now, what if your brain told your mouth numerous times, but your mouth still didn't hear your brain? Would you be frustrated? Would you find another way? What would you do? You can open your eyes. This is how this little girl feels every day. This is speech apraxia. It's our motto for one word at a time. Childhood apraxia of speech is a motor speech disorder that first becomes apparent when a child starts to learn to speak. It has many different names, and I'm sure all my speech friends know all of them. But when I got this diagnosis, I had never heard of it before. All I try to tell myself and other parents when I'm talking to them is just remember, no matter what you call it or you hear it called, praxis just means planned movement. There's a lot of definitions, but one of the ones that I found to be really important was from the Childhood Apraxia of Speech Association in North America. And they said that it's considered a neurological speech disorder that affects the ability to clearly and correctly produce syllables and words. But the most obvious thing that you'll notice is that children significantly have limited or uncleared speech. And this is definitely my daughter. We've had many times when we've been out and about and she's so social and she wants to talk to people and she goes to try to talk to them and just nothing comes out. But you can tell that she wants to say something and she completely understands what they're saying to her, but it's just so difficult to do that motor planning portion. So maybe you have somebody that you're thinking about right now, or maybe you work with somebody, and there's a checklist that you can go through as a parent or as a person that's helping people get the resources that they need. I'm not going to read it to you because obviously y'all can read it, but one thing that really stood out for me was the tendency to consistently move the mouth and lips in an attempt to find the right position in order to make a correct sound. This happens to my daughter a lot. Like, she'll get excited and then she'll just stand there with her mouth open. And it's really hard, like when she was younger it wasn't a big deal, but now that she's in school and she's around her typical developing peers, to just stand there with your mouth open is kind of a little awkward. So it's a big thing to notice and to help like bridge that gap between peers of how you can help her. A lot of the things we do now when we see her do that is we'll be like, oh, could you show me what you're thinking? Or why don't you lead me to where you're trying to tell me? Or I hear you saying this, but I know that you mean this. A lot of the causes of CAS, for my research, they said it was unknown. And so maybe my speech friends can help if it is known, if there's something that is known about it. But they said that a lot of scientists believe that it's related to the overall language development of the student or of the child. But then others also believe that it's a neurological disorder that affects the brain's ability to send proper signals. And I think to move the muscles and to do the speech. And then it happens more in boys than girls. But I'm here to tell you, I've got a girl and it's happening to her. And everybody that we've come in contact with have been girls. So I don't know if that's the case or not. But I want to ask you, what else does it look like? And remember I started at the beginning and I told you it's a personal journey for me. This is what it looks like for me. There's a potential family frustration, right? It looks like there is a lot of time devoted into therapy. And I kind of missed this slide. I'm going to come back to this one. It looks like this. It looks like frequent, intensive, individualized therapy with an experienced SLP. And I'm here to tell you, this isn't our first rodeo. We've had numerous SLPs. My daughter is 8 years old and she just got this diagnosis, which is odd because if you remember my checklist, it talked about things that are happening when they're age 2, right? So my daughter's 8 and we just got it when she was 7. And we're finally making progress, in my opinion, moving us into the right path so that my family doesn't look like this so much anymore. We kind of are moving on to this, the whole Zen portion of it. So I want to tell you that from a family perspective and a personal perspective, give it time. Patience is the key. Work with us. Create a great plan, find that SLP that's going to work with you and do what's best for your family. There is a portion of time that I feel like you have this mourning period where you realize things are going to be different for your child. Not that they're not going to persevere, but that a lot of obstacles are going to come and it's going to take a lot of work to get through those obstacles. But you know what? You can do it. Stay strong. And like I said, have the patience. Something that I've noticed too that it's very common for kiddos with speech apraxia or CAS to learn a word and then come back and just like not have that anywhere. It's just like disappeared. Don't worry, it'll come back. It's repetition. The more and more you practice, the more opportunities you give people in therapy, the more time those words are going to come back. So like I said, it's really important to find that therapist who's going to help your muscles learn to listen to your brain. You're going to give that person vast numbers of opportunities to practice that planning and that programming and to produce accurate movements of speech because it greatly does impact their success. And for my daughter, now working towards this program, to be able to give her those little successes have really helped her want to keep moving forward and speaking because there was a moment there when she just stopped talking altogether because why talk when you're not going to listen to her and she can't get out what she wants to say and you get frustrated and other people get frustrated and presume not confidence, right? So always presume confidence. Some resources that I think are really important, of course, is that one that I talked about before with in North America. It's the first nonprofit organization that we have. And it's a really great resource because it connects you with a lot of families and a lot of professionals in North America to help you out with speech apraxia. But one too that I want to give a little shout out to is Nancy Kaufman, and she's actually an alumnus of Wayne State University, and she's also an alumnus of Michigan State University, where I'm from. And she's just an amazing person, if I can put it out there. I found her in a time when I really needed some direction. And she was able to push us in the right area. Like at that time when I came to her, we've gone to her 3 or 4 times now, my daughter wasn't ready for therapy. And she just straight up told me, she's not ready for therapy. This isn't for you. You need to go do this. And she led us into another avenue. And then it's kind of funny how the world works. We ended up back to her this summer and we were in an intensive speech program with her. And my daughter's just like cruising. She's in school, things are working really well. So definitely check out the Coffins Children's Center if you are not aware of that. It's right here in West Bloomfield. And then I brought prizes too because I was nervous today and I appreciate you listening. These are bracelets and I have to kind of give a shout out being a parent. These are from another parent. She actually created my shirt for today. And the bracelet says one word at a time because like I said at the beginning, that's kind of our motto. Patience, let the words come out, they'll come out soon. But I will pass those around, feel free to take one. And Apraxia Awareness Day is May 14th. So if you want to wear the bracelet and think of me and my daughter, we would appreciate it. And yeah, thanks.
I'm going to be talking to you as a family member. And so,
So my presentation is Meet Patrick. So Patrick, the guy, gentleman, that's my husband. And then these are our 2 twin boys. This is Joseph, and the blonde is Patrick Jr. And my husband Pat has had ADHD his entire life, as long as he can remember. And you know, I've been asking him all kinds of questions. When were you diagnosed? What was it like? What's your experience? So I can try to appreciate this. And so I've learned a lot, probably I'd say a lot more in the last few months, having been in this program, than appreciating anything before. And, you know, when I hear stories about things, you know, I guess I just haven't paid as much attention, or I didn't appreciate it as much. But his mother used to take him to the doctor, to the pediatrician, you know, had the sign, told him signs and symptoms, and never put him on medication. She was afraid to have any more children because she didn't want him to be like him. But she did. He has a brother and a sister that are younger, but that's a story that I have heard. And so he struggled in school. He struggled in elementary school, middle school, high school, and he did graduate on time. We actually went to the same high school and graduated together. And he went into the Navy, and he was very successful in the Navy because it was very structured, which was something that he needed. And now he actually works in skilled trades, so he works with his hands. So he's actually a refrigeration tech at Dow, up in the Midland area where we live. And he is very successful at what he does. He's been there for like 20 years, and he has the most seniority in his department. And he also builds cars, and he restores old muscle cars. And it's all hands-on work. He doesn't put himself in situations where he's got to, you know, do things where it's cognitively thinking or following directions or putting things together. So when I ask him what it's like, and he says, there's a whole lot of stuff up in my head. He says, it's all there. I just don't know how to organize it. He says, it's there. And he says, you know, like, you know, when you say that the house is messy and like your room is a mess, he says, that's what it's like in my head. It's just all cluttered. And so I try to understand it because we know that ADHD has, it potentially, you know, can be passed on. And boys are affected more than girls. And our 2 little guys, they're now 7. They're in the 2nd grade. And I believe that they are ADHD as well. I haven't had them officially tested. But just to give you a little bit more information, that in my 2nd family, I have 4 older children. And so they are not affected with ADHD. So I see a huge difference in between my older children and then my younger ones. And I can tell you that with my personality, being self-diagnosed OCD, it's been a challenge because of me and being ultra-conservative and deliberate with everything. And he's just sort of very carefree and, you know, just
my husband
goes with everything. So that's a little bit of background there. I can also tell you, like, other things that I see in him that he does. He bites his nails a lot. It's one of his things that he does. And he taps a lot, and he also walks, and he paces. Very forgetful, always loses his phone, loses keys. So things like that. So here's a lot of stuff on this slide, so sorry about all that, but it's one of those things you kind of want to include. But globally, there's just a little bit less than 2 billion people on the globe that are diagnosed with ADHD, because some people may not go and get diagnosed. We don't know if that number is accurate. There could be more. But it's been growing over time, just with people actually diagnosing it because and you can see that it's usually diagnosed in younger children, but all through teenage years and even into adulthood. and there is no cure for it. Non-Hispanics have a greater incidence of it, almost double, and some kids have a learning disability. Girls is much lower than the boys, and they usually have the inattention component of it. So the components of it, there's the inattention, then there's hyperactivity, impulsivity, or you can have both. And my husband has both, the inattentive, the hyperactivity, and then the impulsivity. So these are my little guys now. This is Patrick, and that's Joseph. And a little bit about them. He's the mouth. He is nonstop talking. The only time he doesn't talk is when he's locked on a movie or playing Angry Birds or something. And this is Joseph. He's the muscle. He's the quiet one. But he's also the one who will run out in a parking lot and not think. He will come up and push himself way through a crowd of people to get your attention. And they struggle in school. We have a lot of extra help with before school help, tutors, and that to get them at level. We're working to get at level, that's our goal, by like the end of the school year. These are the clinical manifestations with each of the areas, and you can see the different things that I've mentioned with that. So interprofessional approach, diagnosis requires pediatrician evaluation, a psychologist, or it could be a team approach. It's multi-step in the process. They go through a medical exam, hearing, vision exams, and they watch for anybody falling behind, but they have to meet this criteria from the DSM-5. They usually do these Connor scales. They have teachers fill them out, parents fill them out, and anybody else that may be in contact, like coaches or something with that. No cure. They focus on improving functioning, and the medications could be stimulant-based or non-stimulant, psychotherapy, or combination. I will tell you that my husband used to take a thermos of black coffee to school, and he wasn't on medications, but coffee helped calm him down, and he drank that. And just to share with you a little bit, when I go out with my kids, because going to Myers is something I have to be very desperate to do. I make sure I take Angry Birds on the phone. Fidget toys are good in a restaurant because they will play with them because you have a long wait with kids. But they love things like this, just to sit and play with. Cards, things like that. But I have to entertain them and keep them busy to help with that habits and stuff. But if I could have just 1 second, there's something really that occurred to me since I have been in this program, is because I told you I have a challenge, between my style, and it's like I have a hard time understanding why can't they just slow down? Just slow down just for a little bit, let me group things together. And I will say to my husband, what's wrong with them? And he says, in his mind, there's nothing wrong with them. That's their normal. That is who they are. They don't know anything else. He says, he probably thinks you're abnormal. And I'm like, well, I know I can't keep up with them, let alone two. But it was just something that he had said to me before this program, and then he said it again to me like this last week, and I stopped and I thought about it, and I looked at it from a different view, and I believe it's because I've been here and looking at things differently and listening to the parent stories, and I've never thought about that I was like the family member. I've always put myself in the nurse, the healthcare professional position. And so I have a whole new way of looking at it.
That's awesome.
And so it's been just a profound learning experience within my years.
That's really cool.
Thank you for...
So what's the average age of onset? I'm just curious because one of the statistics on your slide was related to 2 to 5-year-olds that have Medicaid that are receiving like clinical services intervention versus primary. So I'm thinking 2 to 5-year-olds are being diagnosed and receiving services for ADHD?
It depends on what source you're looking at, because I found different things, and they say like they're trying to find things younger and earlier, like in the 2 to 5 range. But then there was something else, the CDC was almost, going through childhood and had a lot of information more in the teenage years. But according to the criteria, things have to show up either before age 17 or 12 on certain things. They have to meet so many different points, like on checklists.
Right.
Fill these out, and like, do they do that? But my mentor could, she's the expert.
Yes. So the average age of onset, or not diagnosis, not
Well,
onset.
so before the DSM-5, so our previous diagnostic manual, you have that onset of symptoms before age 7. And then now age 15, but it's also developmentally specific because clearly the demands are different for a 5-year-old than they are for a 14-year-old.
Right.
So as things become more demanding, depending on what's going on with ADHD, we tend to see different impact in the functioning. But yes, I have a hard time diagnosing kids that are under 4 because
So this is from the American Speech Language Hearing Association, so I'm just going to read it right here. It encompasses a combination of difficulties with perception, motor production, and phonological representation of speech sounds and speech segments that impact speech intelligibility. So it also includes problems with articulation past a certain age, because as you know, each child develops differently, and how they adapt to sounds. When you're young, you could imagine that children will get certain sounds and words and mispronounce them, but after they reach a certain age, you would expect them to start picking up the language and start pronouncing it properly. So I actually do have a very short video that is a link, so hopefully it'll work here.
Elizabeth. How old are you, Elizabeth? 3. Elizabeth is going to tell us a story so that we can look at her speech and articulation skills within a connected speech sample. All right, Elizabeth, tell us your story.
Once upon a time, there was a little puppet named Pinocchio. His father painted him, and then the blue fairy come and changed him alive, and then pumpkin nose glowed.
So for time, we can stop it there. But basically, this is an example of articulation disorder. Yeah, so with speech sound disorders, there's usually two different denominations. There are articulation disorders and phonological disorders. So the video that we just saw is mostly within the articulation disorders, which impact the form of speech sounds. So maybe mispronouncing certain letters, and I'll go into several different examples of that soon. There's also examples of articulation disorders could be motor-based, so apraxia, as Michelle, who's not here right now, as she presented on. Dysarthria, which is weakness of muscles of speech. Also those born with cleft palate or other craniofacial anomalies, or those born with Down syndrome. Phonological disorders impact the way speech sounds function together. So it could be they may be deleting or adding parts of a word, and we'll go into some examples of that. So some examples of that could be hearing impairment. So audiology screening exams are really important for catching this in young children. And also with Down syndrome. So epidemiology, so there's actually very limited data regarding this, just because the definition is very inconsistent on its own right. A lot of people don't really know what's going on, and so SLPs will report it, parents and teachers. However, in the very limited data that we had, there is a higher prevalence in boys, and there is a low positive correlation to socioeconomic status. There was a statistic that I read during lunch, so I couldn't put it on here, that said that depending on the reports, 2 to 25% of 5 to 7-year-olds are diagnosed with SSDs. So maybe...
Sounds about right.
Sounds about right. So some key manifestations, omissions. So children will say ool for pool. They'll be missing that P sound, or ka instead of cup. Sound substitutions, so they'll say like thun instead of sun, or wabbit instead of rabbit, or rabbit. I'm an actor as well. Sound additions, so they'll also add little portions such as kalap, or sanap, or balak. And then there's also consonant deletions, so they'll actually delete portions of words such as instead of saying telephone, they may say tayphone or tephone, and things like that. To go on, so it's diagnosing. It's very hard to diagnose because as you mentioned earlier, children develop at different rates. So, a 4-year-old may be saying words perfectly, but then a 5-year-old may still be a little bit slow in picking up language. That's why once it goes past a certain age, usually the developmental milestone or the language milestone is around 8 years old. That's when it's like, okay, we need to see a speech language pathologist and kind of work through some therapy with that. So some testing that we can do oral examinations, hearing screenings, and other possibilities that may throw in some adverse diagnoses would be dialects and accents, which are all beautiful in their own right, and they're not part of the disorder. So yeah, speech language pathologist, we could do articulation treatment with letters, we could do targeted therapy by trying to focus on sounds and improve the sounds of that children. And they usually target in a treatment sequence such as establishing. Last things, to throw in the interdisciplinary aspect and kind of tie it into dentistry as a short aspect. So a lot of the times, pediatric dentists will see children during their early year checkups. And sometimes tongue-tied or ankyloglossia can be misdiagnosed as a speech sound disorder. So what that means is that the lingual frenulum right here will actually be much shorter, and children won't be able to say certain words. So we can all practice it right now. So try saying the word teddy without having your tongue touch the top of your palate. Teddy. So it's very difficult to say words that start with T, D, N. So those are alveolar consonant sounds. And that's what happens with ankyloglossia or tongue tie. So as dentists, we could kind of catch that. We could do a frenulectomy, and we could kind of fix that, and it wouldn't be considered a speech sound disorder. So that's all I have. Do you have any questions?
Dentistry is huge.
Good try. I tried many times last night. But there are no questions, then thank you. Yes. Yes.
I just wanted to add that I think a shared symptom between SSD and Down may come from the fact that a lot of individuals with Down syndrome present macroglossia, or big tongue, and so the mobility of the tongue is impaired. And so that also feeds back to the dental care in the dental chair too for dentists. A lot of people don't like dentists as it is already, but their tongues like us even less. A lot of tongues are fighters, and I think if they're big already, it's really hard to control their movement during an invasive procedure, and it might lead to laceration of the soft tissue. So that's something we need to be careful with.
Yes. Go ahead.
Okay, Emily, go ahead.
Oh, I guess I'm kind of confused. Is it because the roof of their mouth is high, or no?
No, it's because the frenulum right here can be shorter, and so there's no actual cause or reason. We haven't found any specific cause for why the frenulum would be shorter, but in some children it just
it just doesn't reach.
Yeah, so it doesn't reach. Yeah, exactly. So it doesn't reach.
So is it a simple surgical procedure?
Yeah, so you can just snip it. Usually when you're a baby and we catch it, then we can just snip it. In adults, we would usually go under general anesthesia because if I were to go through that right now, I'd be pretty scared.
Yeah.
It would hurt probably a lot. There's also electrosurgery or laser surgery that can be done, which is relatively painless in terms of treating this. So that's another option that we have here. So yeah, it's because it doesn't physically reach the top, not just because the palate is higher.
Would you just put in a local anesthetic and snip it, or do you have to surgically sew it back
so
together?
You use so in a baby you could just snip it with sterile scissors, but then there's another one where you could snip it and then suture it right then and there. So usually for adults you would snip it and then suture right then.
There's not tons of bleeding. You don't have to
I mean, there will be bleeding.
I'm really concerned about
But usually, as oral providers, we usually have suction, and we're minimizing all that.
Raise of hands, has anyone heard of neurofibromatosis before? Oh, wow. Oh, yeah.
I haven't.
So
so-
NF, which is short for neurofibromatosis, is a genetic disorder that can be inherited or not inherited. About 50% of the case of individuals who have it do inherit the disease or disorder, sorry. And then the other kind of 50% is due to a new gene mutation. So it's diagnosed in childhood to adult years, depending on the type of NF that the individual may have. And it's usually diagnosed through genetic testing, looking at family medical history, physical examinations such as eye exams, hearing exams, and so forth. And then there are 3 types which I'm going to go into, NF1 and 2, and then schwannomatosis, or NF3, to just be easy about it. So like I said, it is a genetic disorder that can be inherited. And then if an individual does have the disorder, they have a 50% chance of passing it on to an offspring. And it's about 1 in every 3,000 births have NF. And so we're going to go into that a little bit more. So NF1 is caused by a gene mutation of chromosome 17. It's 1 in about every 3,000 births. And so some signs that can result in this is brown spots on the skin, raised bumps on or underneath the skin, tumors that grow along nervous tissues, and that can result in hearing loss, eye loss, or vision loss, speech problems, other developmental problems, short stature, and things like that. And NF1 is the most prevalent of the 3 types. NF2 is caused by a gene mutation of chromosome 22. This is the least occurring one, about 1 in every 25,000 births. And this results specifically in tumors that grow along both nerves along the ears, sorry. And so that can result in balance problems, possible pain in the limbs and the legs, vision problems as well, and other speech impediments. And then the last one, which actually is recently just kind of coming about, is about 1 in every 200,000. And so there's still research that needs to go onto it, but it results specifically in tumors that grow along the skull, the spine, and the peripheral nervous system. It doesn't result in hearing loss though, so that's why there's a differentiation between NF2 and NF3. And right now, they say the prevalence is about 15% of the population. So these are some of the complications that can come from it, and they vary against severity based on the 3 types. So as you can see, cardiovascular problems, neurological problems, vision problems, hearing problems, breathing problems. So there's a huge gambit of things that can occur based on this diagnosis. And so because of that, multiple teams and multiple professionals have to come together to come up with a plan. So it's a lot that needs to be navigated based on the parent and the families and the individual themselves to be able to manage it. And managing it could be against various therapies, surgeries potentially, and just being able to manage a healthy growth development with the individual. So specifically, my brother has NF, so that's kind of why I touched upon this a little bit more. And I wanted to focus on the kind of the multiple disciplines aspect of it, because coming from a personal aspect, it's very difficult to manage all these different components to be able to create this plan for this individual based on this like one diagnosis that they have. And so being able to not only advocate for yourself as the individual who has the disorder possibly, but also the families, because there are so many different professions that have to come together and to be able to manage it. It's a little difficult. So I had to, didn't mean to do that. The CTF Foundation, which is the Children's Tumor Foundation, formerly known as the NF Foundation, has like all this information on it. And then the NF Network for families to collaborate with each other so that they can create an advocacy group for themselves to be able to communicate with one another about that. And yeah. Yes.
What's happening in, what is it, schwannomatosis? What's happening to the myelin sheath and the peripheral nervous system? Is there tumors growing on it, or does it start to deplete?
So, from my knowledge, just because I know more about NF1 and 2 than this one, this is kind of a new research thing that I found, but I think tumors grow along the myelin sheaths, but it specifically results in only tumors growing on the skull, the peripheral nervous system, and the spine based on that.
Do you know if it affects like kinetics and body movement?
I'm not sure about that. But I think it, based on all these complications, one of the complications is a loss in some motor functions and things. And so all of these can go across any one of the 3 types. So from my understanding, it would then. Yes.
With your brother having NF, does he have one?
Yeah, yes, yeah, sorry.
And you mentioned, the importance of the multidisciplinary team. It might be interesting to create a care map.
Yeah, no, that's.
To look at all of the different, all the medical, there's a whole lot of medical there, but there's a whole lot more than the medical. To be able to think about all of that. And as a pediatrician, I've had a number of kids with NF1 in my practice, and learning issues and ADHD.
Yeah.
Very common in my experience in kids with.
Yeah, it's interesting because when I was in undergrad, I interviewed my brother kind of for one of my classes, and he didn't identify as having NF. When I asked him what his disability was, he identified as having a learning disability and ADHD. So it's interesting because a lot of learning disorders come out of this.
Yes.
So it's kind of, it's interesting. We have to teach the individuals who have this disorder to be able to advocate for themselves and all the complications that they have.
I was going to ask, are the 3 different types all autosomal dominant, or are any of them recessive?
From my understanding, they're all autosomal dominant.
Okay.
Yes.
If you don't mind, just to get a picture, like what symptoms does your brother present?
So you wouldn't know that he had a disability from face value, but he has like the light brown spots that look like freckles. He does have some tumors that have grown along the optic nerve. Short stature, but his main complications, I would say, would be learning disabilities, ADHD, things of that nature.
So could you evidence that some of the symptoms can be managed or mitigated?
Yeah, so there's no cure for it. Yeah, so there's no cure for the disorder, but it's mainly managing any pain that could occur, behavioral issues or speech issues or learning disabilities. Yeah.
What is like the long-term prognosis for people lifespan?
So I think it's just managing it amongst the lifespan, because it just is something that the individual will have to manage for the rest of their life. So like my brother, for example, it's not, it doesn't affect him greatly amongst the learning disability aspects of it. And then also like currently right now he has like a girlfriend, so he's going through the whole process of like the fact that if he does have a child, he'll have 50% of passing it on, and it could be at F2 that he passes it on to, so it would be more severe.
So tough.
NF2 can be fatal.
Yeah.
So it depends on
That's why
where
it's
the
exciting.
tumors are and how big they are and whether they can be managed surgically or radiologically.
Yeah, based on what I found, most of them are benign, but they can become malignant.
Well, it's not just it's the size of the tumor.
And where it is.
Where it is, right?
Yeah. We see NF2 patients a lot as audiologists.
Oh, wow, okay.
Yeah, sorry.
I was just going to ask, do you know, you said he has tumors that grow on his optic nerve. If they like progress or extend to the optic chiasm, would there be blindness or
Yeah, so
difficulty in-
there's a potential of vision loss. So that's something that like my parents have like gotten a lot of testing and help with. That it hasn't affected him yet, but as like he gets older and things like develop and grow, it could cause yeah.
I had a client that had neurofibromatosis, and he grew a tumor that crushed his optic nerves, and he was born with sight but went completely blind.
This picture up here.
Awesome.
You all can see it. I just wanted to start off by telling you a little description of this little girl who was up for adoption. The bio was, she's a petite child with a cute face and a well-proportioned body. She is developmentally age-appropriate in her interactions and behaviors. She's observed to display some assertive skills by standing up for herself. She was born with multiple medical problems. She was born with multiple defects, including a small brain, heart defects, and duodenal atresia. She experienced heart surgery, bowel surgery, and a G-tube placement in her first week of life. She had her second heart surgery at 5 months of age, which caused a damaged vocal cord, which resulted in a quiet voice and difficulty swallowing. She has severe hearing loss in the left ear and mild in the right. She has hearing aids. She has astigmatism and is farsighted. She has global delays related to small brain development, failure to thrive in the first year, but is making progress. She has a G-tube. She has a tendency to experience episodic reflux due to a prolapsed vocal cord and has a tendency to aspirate. She has a very special little girl in need of a special home. Her new family will need to be willing to support her long-term medical care and therapies. She'll need to live in close proximity to the institutions that will provide her with these long-term services. The adopted family will need to have enough medical background to understand the needs that she has, with various medical and therapeutic providers to address her developmental delays and disabilities. I have to tell you, I'm the adopted mom of this little girl, and that's the information I had when she was 3 years old. Thinking, okay, not a problem. I can handle this. I'm a nurse. I know how to do a G-tube. I know sign language. She's hearing impaired. I get it. I think we can handle this. So, fast forward to 2017. She's now 15. Angela came to us with an initial diagnosis of Opitz G-BBB. Did I say that right?
What is it?
Opitz G-BBB. It's a genetic condition based, when we adopted her, solely on features. They told us when we adopted that long about her teen years there would probably be a blood test to be able to confirm that. So I sought a genetic referral to get her in to have that test done. Forwarded all of her medical information to the geneticist, and when we finally got in, like Candy said, it takes forever, almost 2 years later, to meet with a geneticist. She looked at her history and she said, I'm not sure that she has that. So I went to do a physical examination. She says, I think she has Charge syndrome. And I said, never heard of it. Wasn't sure what it was. Until I started reading about Charge. And I'm like, yep, 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 yep. More so than the Opitz diagnosis. So what is Charge? It's a recognizable genetic syndrome with a known pattern of features. It's an extremely complex syndrome involving extensive medical and physical difficulties that differ from child to child. And the CHARGE stands, each letter stands for a different part of their body that's involved. Key features of coloboma, which is almost an incomplete closure of the pupil of the eye. It's like that circle is being dragged down. Cranial nerve abnormalities, corneal atresia, heart defects, characteristic external ears, esophageal defects, smaller abscess semicircular canals, genital urinary abnormalities, and CHD7 mutations, which is what they're going to test for. This is not my daughter, obviously. That's another little girl who exhibits the signs of Charge syndrome. Coloboma, there's cranial nerve, heart defects, atresia of the choanae, retardation in growth and mental development, genital abnormalities, ear malfunction, and or hearing loss, and 4 of those 6 characteristics must be present for a diagnosis. The diagnosis should be made by a medical geneticist, which is what we did. Diagnosis is made based on key features and ideally with DNA testing for the CHD7 mutation. The incidence is 1 in every 8 to 10,000 births. Doesn't run in families. However, if the parent has Charge, the risk to the baby is 50-50. Because she's adopted, we don't have that information. The biological mother actually had some of the facial features of Opitz. So, but we don't have, we'll never have that information. There's an increased mortality, especially in the first 2 years of life, due to the complexity of the symptoms and possibility of delay in diagnosis. Obviously, my daughter is 15, we're just maybe now getting a diagnosis. Because she had had her first open heart surgery at 5 days of age, her second one at 5 months, her third one she actually had with us at age 4.5. And she has more to come because she has still got 3 faulty cardiac valves. She does have hearing defect. She has hearing aids both ears. She is missing semicircular canals both ears. They told us she would have trouble with balance all of her life. She may never learn to ride a bike, but the good thing is she'll never get dizzy, which she never does. And she actually learned how to ride a bike before my older daughter, so balance has not been an issue with her. Because of the severity, the challenges vary so much with each child. It's like just about any of the disorders, you know, they run from the mild to the severe. The highest level of functioning is obviously sought after. A lot of these kids have what they call deaf-blind, so they have vision issues, they have the hearing issues. They may have cognitive delays, which is going to result in the need for support for years. Complex medical syndrome requires numerous specialists. Families required to devote time and energy attending appointments, developing specialized plans of care, and becoming an advocate for the needs of their child as their needs change. This can be an overwhelming task for a lot of families. But children with charge can survive and become happy, productive citizens, as one of the hidden features of charge syndrome is the determination and strong character that they display. I have her genetic report, and I'm not going to read everything on it. But she has all except the eye part of the diagnosis. And I actually had an ophthalmologist look at her just the other day and said, you know, they're looking at charge syndrome. He said, charge syndrome? Well, let me take a look. So that is probably the only characteristic that she does not possess. But she is 15. She's a 10th grader. She's in the band. She has dyslexia. She struggles with school. She doesn't like school, and she has no filters, and she'll tell her teachers, I don't like school. Why would I want to learn Spanish when I spent the first 14 years of my life trying to learn English because I'm hearing impaired? So, any questions on charge? We have not yet received a diagnosis. The blood sampling went out. It will take 4 to 6 months to come back. So, in the meantime, you know, we just keep on keeping on.
Why does it take so long?
Because, well, it was so long to actually get the insurance to approve it. They wouldn't approve the OPITS, which was a basic, simple test, but they did approve exome genome sequencing. Much more complicated, much more expensive. But it's only done out of state and takes that much money.
Private
It's really frustrating to wait so long for a diagnosis and to see now as a teen that, you know, that what the diagnosis she's been carrying is, you know, the label that was given earlier is probably incorrect. Looking back, would medical decisions or educational decisions or therapy decisions have been different with the diagnosis? Does it change? You know, because you're addressing her heart problems, addressing the educational issues. Would it have made a material difference in the decisions for her treatment? I mean treatment in the broadest sense.
For us, I don't think so, because I think, you know, we were looking for confirmation as to OPITS and what that is going to mean should she decide to have kids.
Okay.
But we're also, you know, we're coming from a well-educated background, and I tend to stay on top of everything going on with my kids. If there were another charged kid that, you know, parents weren't as diligent about seeking those things out. And with charge, what's going to change is, and with the genetic testing, we could tell the geneticist how much information we wanted to know. Did we want just the diagnosis? Because with the exome sequencing, they can actually look and see what she may have in the future based on that genetic study. So we had 3 different levels of where we could decide how much information we wanted. We went to level 2, saying, is this going to change her course of treatment in the next 10 years? Can we look and see, will she have Alzheimer's as an adult? They may be able to pinpoint that. At this point, we didn't want to know that much information. She can go back when she's in her 20s or whenever, and she can actually have them pull that information out and get a little more information. But we decided with her sitting in the room with us, that's what we wanted to know right now.
My presentation is on auditory neuropathy spectrum disorder. So what is ANSD? Auditory neuropathy spectrum disorder, there's a transmission, or a problem in the transmission of sound from the innermost part of the ear, or the cochlea, that snail-shaped organ, to the brain. So neuropathy implies a dysfunction of the nerve. But we know with auditory neuropathy spectrum disorder, it can be a problem elsewhere, such as the inner hair cells of the cochlea. It can be a problem with the neurotransmitter between the nerve, the hair cell, and the nerve fibers, demyelination of the nerve. So in 2008, the name was switched to auditory neuropathy spectrum to kind of better categorize what the disorder is. So the etiology, individuals who are most at risk for ANSD are those who are in the NICU, so specifically those who have hyperbilirubinemia, have received ototoxic medications, which are toxic to the inner ear, individuals who've had ventilation use, and that was it? Okay. And then, so 40% of individuals with ANSD have a possible genetic basis. So specifically, connexin 26, which is a gap junction protein associated with hearing loss, has been connected to ANSD, as well as otoferlin, which is another protein that they have recently connected with hearing loss. There are also some syndromes that have been associated with ANSD, such as Charcot-Marie-Tooth and Friedreich's ataxia, which I think somebody's doing that, right?
What?
Just kidding. No? Yeah? Oh, just kidding. I thought somebody was doing that too. So kind of our textbook presentation of ANSD, they'll have present OAEs. So what this means is that their outer hair cells are functioning well. And if you recall earlier, I said that the inner hair cell can be damaged. So outer hair cells are good, inner hair cells maybe not. We have an absent or abnormal ABR. Absent acoustic, ABR is an auditory brainstem response. So it's the brain's response to an auditory signal. Absent acoustic reflex, which is a muscle in the middle ear that contracts when there's a loud noise present. It's a protective mechanism of our ear. And then inconsistent speech rec scores with their behavioral thresholds, meaning that their hearing levels might be okay, but their speech rec scores are far poorer than what we would expect. And their hearing can range from normal all the way to profound. So there are certainly disparities in this diagnosis. In Michigan, 99.1% of newborns have their hearing screened, which is great, but we need to determine what type of screening they're receiving. If they're getting OAEs, which measures those outer hair cells, they're going to pass. If they have an ABR, it would likely be absent or abnormal, so they'd get a referral. But again, if they're only getting OAEs, these kids could be lost and we wouldn't catch it. So it's so important that they have a very full, comprehensive ABR as well, and that these kids aren't lost to follow up. The good news is that kids in the NICU, which again, they have a high risk factor for ANSD, they will likely get an ABR as they're screening. So this is definitely a big team approach. The JCIH recommends that they receive care from their pediatrician. They have an otologic eval, genetic eval. Again, 40% could be connected to genetics, so that could be very important. See an optometrist or ophthalmologist. Really, any kid with a hearing loss needs to get their eyes checked because they may be relying on one sense more than the other, so it's crucial that they have their eyes checked. And then, of course, the speech-language pathologist, again, their speech recognition can be poorer than we'd anticipate with their hearing levels. So treatments, these kids can do really well with hearing aids. Previously, we thought, since they had those healthy outer hair cells, that we didn't want to provide too much amplification because we don't want to damage their hair cells and damage or cause more hearing loss. So, but recently they've determined that fitting them with a hearing aid that's as similar as what you would fit with a child with sensory neural hearing loss, that they'll perform very well. And also a cochlear implant to kind of help with that dysynchronous firing of the nerve.
was it? But I did take out some stuff because I didn't want to go over time. So I did want to say that the incidence of this is 8%, and that was as of 2002. However, this is a relatively new disorder, so that's likely higher now. And we know that the NICU, they have new technology, and that the care that they get could be better now. So that percentage is likely to be higher today. And this occurs in 10 to 15% of all kids who have sensory neural hearing loss. So it's not as rare as we once thought it was.
I'm just wondering, so the incidence of 8%, is that in the high-risk population, or is that?
That was the stat that I found. It was from 2002. It was just of all kiddos, so 8%.
And then one other quick question, is chemotherapy?
Yeah, so that is considered an ototoxic drug, which can damage. Yep, so it is a risk factor. Yes.
Can I just give a plug for the Eddie program? So
Yeah,
newborns that don't pass their hearing screen, I actually do Eddie follow-up at the health department. They send that to whatever county the kid is in, and hopefully somebody in the health department follows up, calling the parents to see if they had a rescreen done, to see what the results were. And that's all sent back to the Eddie program so they can track those kids that didn't pass their screen.
Yeah, I have to say, because my daughter did not pass hers in one year, and I don't know what point it was, I got something in the mail saying, your child did not pass. Did you follow up? I'm like,
Right, yeah,
no,
so
we have not. So
it's so important that.
and I was very shocked to find out, yes, she had
Right.
hearing loss, and I did not know.
And loss to follow-up is really high, unfortunately, and so it's so important that kind of everybody that's involved in this coordinated care, some, as we heard last week, some pediatricians might say, you know what, it's probably just fluid, don't worry about it.
Right.
But that's so not true.
Right.
And not to be over concerned though, because it could just be fluid, but it's so important that they do see an audiologist for.
You're right, and a lot of times, people who have children with Down syndrome say, oh, because the fluid it
Right.
comes in back, they don't need to wear hearing aids. And I'm like, I tell them, no.
Right. It's so
You know, my daughter's speech just really boomed once she started. She doesn't like wearing them still to this day, and you can tell. I mean, Lily, I don't understand one word you're saying, but they bother her. She doesn't like wearing them, but her speech is much better with them.
Yeah.
I have a question. I don't really know anything about your field. So like a kid gets born, has a defect, they get put in the neonatal intensive care unit. How do you determine whether or not it's like a problem with like the tympanic membrane or the philophadia, or how do you like specify that it's just this? Like what kind of diagnostic test?
Yeah, so we have different tests to kind of test the different parts of the ears. So if it was a problem with the tympanic membrane or the eardrum, we do tympanometry. So we measure how the eardrum is moving when we introduce pressure to it. To test the cochlea, we might, if they're old enough, we do behavioral testing. So when you hear the beep, press the button. Or an ABR, which is a more objective test that we can measure the entire auditory pathway to the brain and how they respond to an input of a signal. So we can test different parts of the ear along the way.
That's so cool.
We have a whole module on audiology.
Yeah, it's really good.
A lot more. It is really cool.
Thanks.